This week on the BackTable podcast.
These combination units, the hybrid units, CT and fluoro, really allow us to switch among the different modalities to the one that suits us best for the part that we're treating. So, for instance, sometimes I'll do an embolization first for a hypervascular lytic renal metastases to the iliac bones. Embolize first, so that's a local pain treatment. It also prevents bleeding in the next step when I push the patient in the scanner and perform a screw fixation.
Sure.
So there are a lot of different creative options with those combination units.
Welcome to the BackTable podcast, your source for all things endovascular or otherwise minimally invasive. You can find all previous episodes of our podcast on iTunes, Spotify, or backtable.com. Subscribe to the podcast, leave us a review, or reach out to us on Twitter or email to let us know how we can make this a more valuable resource for the endovascular community. Today's episode is sponsored by OsteoCool RF Ablation by Medtronic. OsteoCool is internally cooled radiofrequency ablation technology that can be used in the spine and peripheral bone. Its dual probe capabilities allow you to approach a lesion with two probes simultaneously for tumor coverage. Know where the heat is going and map out your ablation zone before treatment. You'll receive a controlled ablation as the generator automatically measures impedance and modulates power to deliver energy consistently. Visit medtronic.com/osteocool to learn more. The information and opinions expressed in this podcast are those of the presenters and moderators only and do not reflect Medtronic's views. This is Michael Barraza, your host for today's episode, recording from Baton Rouge, Louisiana. Today, we're going to be talking about percutaneous ablation of osseous metastases. We previously covered ablation of spine metastases, and more recently, we discussed introducing spinal ablation in conjunction with radiation oncology. Today, we're going to be focusing on treating extraspinal bone tumors, and it's an honor to welcome interventional radiologist Dr. Steve Yevich from MD Anderson and UT Health Science Center to help guide us through this. Steve, thanks for sharing your time and expertise with us.
Thank you for having me.
So, Steve, between Hopkins and MD Anderson, you've gone from one oncology mecca to the next, but you had an interesting stop in between. Can you tell us a little bit about the clinical fellowship you did in interventional oncology in Paris?
Of course. It was a great year. Essentially, how it worked out was I was finishing up my fellowship at Johns Hopkins, and I really wanted to learn the latest and greatest in interventional oncology. And I asked the faculty at Hopkins, I said, well, where should I go to learn the latest and greatest of interventional oncology? And I can go anywhere. I was single. I traveled and interested in really focusing on this career development. And they unanimously told me to go to this hospital in Paris, France, called Gustave Roussy. And funny enough, I had asked the same question a year earlier to Marshall Hicks, who is the department head at MD Anderson, and he had given me a business card. And on that business card was the name of the department head of interventional oncology at the same hospital. So all people pointed to the same department, to the same man, who was Thierry Debert. And that's what made me decide to go over there and learn these new techniques.
So how did you set that up? You just take a business card and call and say, bonjour, and just set that thing up just over the phone?
That was basically it. I'd sent him an email, and at that time, I didn't know how to call to France. And
I don't know how.
Yeah, so I sent him an email, and he kindly replied. He's quite a busy man, but he makes time for everyone. And he said, sure, let's make it happen. And about 6 months later, I had learned enough French to pass a basic French test at the Alliance Française in Washington, D.C.
Right on.
I had completed all my visa paperwork, and I had submitted to be formally enrolled as a resident/fellow in the French medical education system.
That's awesome. What a unique experience. Yeah. And, you know, the latest and greatest is clearly a torch that you carried with you to MD Anderson. You know, perusing through your publications, I noticed a very wide variety of topics that covers essentially the gamut of oncologic interventions in our specialty. But in particular, you've published extensively on ablation and other percutaneous therapies for osseous metastatic disease. So would you mind starting by just sharing how or why this has become a major part of your practice and how it's evolved over these last been 5 years since you've been out?
Yes, I really have to attribute my development to this group in France. They did a wide range of treatments, and really their mantra was everyone should be good at everything, and they certainly are. So one of the things they taught me was how to treat bone lesions either by ablation, embolization, or fixation with cement or screw placement. And among the other things, liver, kidney treatments, lung treatments. And so when I returned back to the U.S., I really wanted to work in a large oncology center, and I interviewed at several, and MD Anderson seemed to fit the bill for me at that stage. And they hired me, thankfully. And when I showed up, I said, well, thank you for having me. What should I do from here on out? What do you want me to focus on? And they said, well, we have enough people doing liver treatments and we have enough people doing kidney treatments. How about you start on bone and maybe from there go into lung? And I said, sure, that sounds good.
And so, you obviously had a pretty good background of doing these in France, but, how did you grow it at MD Anderson? How did you grow the practice just from starting out?
Yeah, that's a really good question. And I think the most important thing I had to learn was how to identify the individual needs of the hospital. First off is what do the referring providers want? What makes their life easier? The second is what is the patient mix? Where are they coming from? How do they get referred to me? What are they interested in? And so it took probably about a year to understand that system. And it was a lot of self-promotion. It was a lot of me just emailing and calling providers, going to give small little presentations in their tumor boards or their morning meetings. And eventually, certain oncologists would send me patients here and there. Some surgeons would send me patients here and there. And typically, they were the very challenging cases where a good outcome was not really expected, but there was nothing else that they could offer that patient. Sure. And so they were hoping I could do something for them.
Well, it's interesting coming from, a renowned cancer center like MD Anderson, you're probably dealing with referring doctors that probably know more about the available treatments than some of the average oncologists out in the community. But, in your experience, both starting and where you are now, how do these patients arrive in your clinic? Are they referred specifically for evaluation for ablation or really just help with, either tumor control or pain management?
That's a great question, because what I found was even though these oncologists are just experts in what they do, they are absolutely fantastic. Often they don't know what we can do. And many times when I get referrals now, they just send a request for help, either for pain palliation or potential for tumor control, or it might just be a referral that says, please evaluate the iliac bone metastasis. And that's all it says. And sometimes it's even I found out later on, and this certainly has been happening more and more in the last year or two, it's the patients that are asking their oncologists or their surgical oncologists for certain treatments. And the oncologist will say, well, I know Steve Yevich or one of his colleagues, and I'll reach out to them via email or a formal consult to see if this might be an option.
Interesting. So, we both know that, doing these bone ablations, they're going to vary widely based on lesion, location, associated fracture, et cetera. And that we could easily devote an entire episode to just treating like sacral or acetabular lesions, for example. But I thought we'd try to cover just some of the basics. And to begin, one question I had, are the vast majority of these that you're doing, are these palliative interventions, or are you doing some of these with more curative intent?
The majority are palliative, and I would say between 10 to 20% are really curative. Some might be a mixture where it starts off palliative and the tumor locations become more manageable, either by some type of systemic therapy or by my repetitive interventions, and it turns into curative, or vice versa. It might start curative and then the patient unfortunately develops metastases in other locations and it reverts to palliative focus. It's really highly dependent. I think that's why it's so interesting for me and fun for me, because every patient is a little different, and it certainly have to exercise a lot of creativity.
Are there any other indications that you're using for treating these extraspinal bone lesions? I know, for example, in the spine, occasionally we'll have something come up where, we'll treat and then cement a lesion for fracture prevention.
Mm-hmm. Yes, very similarly in the pelvis, any weight-bearing portion of the body, I might cement or place screws for prevention of fracture or ablation as well. Occasionally, I might do soft tissue ablation around nerves, and that's really to prevent those soft tissue tumors from enlarging and compressing upon a nerve. I only get a few referrals from certain oncologists and surgical oncologists that are mindful about these things.
Yeah.
And that takes a lot of education, and I do a lot of emails with the referring providers, and I'll occasionally suggest that I can treat a particular lesion that maybe they hadn't referred that patient for, just for a preventative purpose. In case it grows, it might cause a problem.
Sure, that makes sense. So what are some of the more common locations of the metastases that you're treating?
I'd say the most common location is in the iliac bones and the iliac spine, the acetabulum, and the iliac crest. That probably is the bulk of the extra-spinal disease that I treat. There are occasional rib lesions that will be referred to me for pain palliation. And then oddly enough, some shoulder metastases that also come to me.
Ribs, that's pretty tough. I mean, even doing a biopsy of a rib lesion is hard if it's small.
It certainly is. And the other thing that makes it a bit challenging is that ribs are out of plane for us, and they're very slender. So to gain access can be quite a headache.
So, Steve, when you're evaluating a patient with bone metastases, what are the primary lesion-specific or anatomic considerations that determine if it's feasible or not for ablation?
Right. So ablation, the first thing I look at is location. What are the surrounding critical structures that I might damage with that ablation? And those are typically nerves. I certainly don't want to permanently damage a motor nerve. That's paramount concern for me. Sensory nerves, I evaluate whether or not or how critical that sensation will be for the patient if that is lost. So that's the first thing I look for are surrounding nerves. And there's certainly a few good articles in our IR literature about location of nerves and damage from ablation.
So, I know that this is going to vary by location, but are there any particular contraindications or any problem lesions or locations that come up a lot?
So in the pelvis, it's really the sciatic nerve that causes the biggest issue for me. Okay. Occasionally the sacral nerve roots, if there's a sacral fracture or sacral lesion. And then the L4 and L5 nerves, as they wrap out of the lower spine, will travel anterior to the sacrum, and that's always a location that I'm worried that I might extend an ablation zone in the sacrum and inadvertently damage one of those nerves.
Does the type of metastasis matter, in terms of efficacy or safety?
No, and that's the great thing about ablation. If we understand which tools we're using, whether it's microwave, radiofrequency, or cryoablation, and we're able to apply those tools appropriately, we really can treat any location, any type of tumor.
Well, let's take that a little bit farther. What ablation modalities are you using and where?
So I'll predominantly, for bone ablations, I'll predominantly use cryoablation.
Right.
And I tend to do that because, number one, that ablation zone will propagate through any tissue. So that ice ball will continue to grow, whether there's bone or muscle or any type of tissue that's there. It won't damage arteries. So if there's a critical artery in that zone of ablation, there's a very minimal risk of permanently damaging that artery. And it's also very slow. It's a slow process. So while it does take a lot of my time to make sure I do a good ablation and completely cover the lesion, I'm not caught by surprise, which can sometimes happen with microwave ablation in particular, as it's going through different tissue densities.
So have you ever had to do any of these with, where there's already hardware in place?
Yes. How
do you manage that? One, in terms of, modality selection, but two, not causing any damage?
Usually with the metal hardware, I'll stick to the cryoablation. Certainly reach out to the orthopedic surgeons, routinely in contact with them, and I just alert them that I'm going to do an ablation here. I typically will either have them follow up in my clinic or send them to the orthopedic clinic a month or two later. just to evaluate for stability. And it certainly depends on the size of ablation that I'm going to perform, whether that location is a weight-bearing location. I think that's extremely important in approaching the bony structures of the body to identify what are the forces that bone is supporting or resisting, rather.
So, Steve, I'm not personally using microwave for bone right now. I'm curious if and where you're using microwave.
So I typically use microwave for large lytic lesions that I would like to ablate rather quickly.
Okay.
And particularly if it's a palliative ablation, for instance, large renal lytic lesions in the pelvis or in a rib perhaps, and the expectation is pain palliation. I love how fast microwave will perform the ablation, but I'm always hesitant for the smaller lesions because I'm not sure where the edge of the ablation will be given the different densities typically in bone lesions.
Another question I have for you, Steve, is when and where you perform cementoplasty after ablation, and if there are any circumstances where ablation alone is sufficient without cement after.
So the only time I inject cement after ablation is if it's a load-bearing or weight-bearing bone. And for instance, the acetabulum,
right,
the strip of the iliac bone that extends from the sacroala to the acetabulum, that's a weight-bearing portion. If I'm working in the scapular neck, that does support the humeral head, so I'd rather that not compress. Certainly the vertebral bodies, so those weight-bearing areas. And the only reason why I wouldn't inject cement after ablation in those areas is to monitor for local control.
Understood.
So, for example, if I have a superior acetabular lytic lesion and it's perhaps a patient with oligometastases, or perhaps this is their only location of disease, I'll do the ablation first and recommend that the patient use weight-bearing devices such as crutches or a cane for the next month or two until their next PET scan or MRI to evaluate for total tumor control. And if there's any recurrence, then I can confidently go in there and touch up that area and then inject the cement. And if there's no recurrence, then I can proceed with cement injection. And that's very comforting for the patient and also for the referring oncologist or surgical oncologist. They like knowing if there's total tumor control or not.
Sure. Right on. So, Steve, let's talk just for a moment about some of the more advanced techniques that you're doing following ablation. You've published on this. You mentioned you learned this in France, post-ablation or even, without ablation, cemented screw placement for pelvic fractures or really anywhere else that you're doing some of these procedures that are otherwise usually done by orthopedic surgeons.
Yes, this was a great thing for me to learn in Paris, and Frederic Deschamps is the man who taught me. He's really been a pioneer in this field that we're growing into. And the reason why IR is moving into this arena is that we have the imaging technology that is really superior to the C-arms that surgeons have to use. So the orthopedic surgeons actually have to, or many of them that do these types of procedures, they take an entire year fellowship in order to learn how to do these pelvic screw fixations. And they really focus on trauma. So for the niche of interventional oncology, we have the added advantage of the fancy imaging equipment, the image guidance and navigation tools that we can overlay our trajectories on our either fluoroscopy or CT and follow those tools. And we also are probably the best at cement injection through needles. And
I agree.
Yeah, it's certainly I've heard over and over again from surgeons when they see my work, they just can't imagine how I am able to get the cement where I want it to go without doing an open procedure. And so that's certainly a big advantage of our specialty in our practice.
So, I mean, is the screw fixation something you're doing frequently?
Yes, it's I'll do between 2 to 4 cases a month.
Oh, wow.
Yeah.
Any pushback at all from the surgeons or anyone else?
Not at this time. I really approached this with purpose and forethought. I needed to ensure that my operating area was to the same standards as the OR, which luckily enough at MD Anderson, that was the new building that we moved into right when I arrived, was to the same standards as the OR. And then I approached the orthopedic surgeons. That was the first group I reached out to. And I showed them some of the work I'd done before and in France and what I'd learned. And I worked with them closely on the first few cases in terms of telling them what I was going to do. And so I would frequently screenshot the pelvis. I'd maneuver it on the Leo or our imaging devices, and I would draw out either using PowerPoint or Paint or whatever, design tool we have on the computers to show them where I'd put the screw, and then I'd draw out where I was going to inject the cement. And after several months of me doing these types of cases and having good results, I do that just as a courtesy, because they've gained confidence in my work. Right. That makes sense. I do know that in my situation, I certainly benefit from that year of training, and I know a lot of my current trainees, whether they're residents or fellows, they might not get to do very many of these while they work with me, because MD Anderson's such a big place. So they might work with me, 1 or 2 days a month and rotate through the other faculty. So many people get started in the U.S. with these types of cases that are unique. Sometimes it's not a bad idea to buddy with orthopedic surgeons, and that certainly brings up differing opinions on how close to get to other specialties. Right. Might be a topic for a whole nother podcast.
I think you're right. So is there a role for preablation embolization in any of your cases?
Yes, in 2 cases. If I want to get local control of a tumor, so if the tumor's small, or maybe it's a oligometastatic patient, then I'll try to get that tumor control. So that's the first reason. The second reason is if it's a very large tumor and I'm worried that the systemic therapy, whether it's chemotherapy, immunotherapy, or even radiation therapy, might not be effective. And in those cases, I'm worried that the tumor will continue to grow and will outstrip my screw or my cement. And so all the work I did would have been for naught.
Got it. Steve, I got one more question for you, and you've published on this as well, mainly on the role of advanced imaging in performing bone ablations or really any other percutaneous osseous intervention. How does it change your approach to these? Or what are you using, and what has this really opened up for you?
So there are a few different devices or technologies rather that have really expanded the potential. One of them is our intervention tools on any of our equipment. No matter the manufacturer, there's interventional toolkits that you can overlay the location that you'd like to cement with a certain color, or you can outline it. And so under fluoro, that outline will stay as you move your fluoroscopy C-arm. So that's the first one. The second one are these combination units, the hybrid units, CT and fluoro, that really allow us to switch among the different modalities to the one that suits us best for the part that we're treating. So, for instance, sometimes I'll do an embolization first for a hypervascular lytic renal metastases to the iliac bone. So embolize first. So that's a local pain treatment. It also prevents bleeding in the next step when I push the patient in the scanner and perform a screw fixation.
Sure.
So there are a lot of different creative options with those combination units. And the last one is the fusion imaging capabilities, where we can fuse either a MRI or a PET scan to our fluoro or ultrasound to guide needle placement.
Right on, Steve. Well, that is about all I've got. Is there anything else that I didn't cover that you want to talk about?
No, I think we covered a lot. I'm certainly willing to come on again in the future if there's something else that comes up.
Take you up on that.
That sounds good.
We're grateful, Steve. Thank you for sharing your time with us. And thanks to all of our listeners for joining us today. We'll catch you on the next one.
Thank you.